Autophagy, while traditionally seen as a cellular self-preservation mechanism, takes on a far more insidious role in the context of cancer therapy. For many cancer cells, especially those subjected to the harsh environment of chemotherapy, autophagy becomes a survival tool, a way to adapt, resist, and ultimately evade death. By clearing damaged mitochondria, reducing oxidative stress, and recycling nutrients during metabolic crisis, cancer cells use autophagy to withstand therapeutic assaults that would otherwise be lethal. This protective autophagy is a major contributor to chemotherapy resistance, and understanding it has opened the door to a provocative but increasingly urgent strategy: deliberately inhibiting autophagy to sensitize tumors to treatment. Chemotherapy is designed to induce cellular stress and death, often through DNA damage, oxidative injury, or metabolic disruption. Normal cells, which have intact damage response pathways and low proliferation rates, often halt growth or die in predictable ways under these pressures. Cancer cells, on the other hand, are genetically unstable, metabolically rewired, and highly adaptable. When faced with chemotherapeutic agents, many tumor cells activate autophagy as a countermeasure, buying time to repair damage, restore homeostasis, and resist apoptosis. This is especially evident in solid tumors where hypoxia, nutrient deprivation, and inflammation are already prevalent, conditions under which autophagy is naturally upregulated. A growing body of evidence shows that autophagy plays a key role in treatment resistance across various cancer types. In pancreatic cancer, for example, one of the most lethal and treatment-resistant malignancies, autophagy is hyperactive even at baseline. Chemotherapy, particularly agents like gemcitabine, further ramps up autophagic flux, allowing the cancer cells to recover and repopulate. Similar trends are seen in glioblastoma, breast cancer, colorectal cancer, and non-small cell lung cancer, where autophagy inhibition has been shown in preclinical studies to enhance the cytotoxicity of standard chemotherapy and radiation. This has led to the exploration of autophagy inhibitors, with chloroquine and hydroxychloroquine, originally used as antimalarial drugs, repurposed as adjuvants in cancer therapy. These drugs block autophagosome-lysosome fusion, effectively stalling the autophagy process and causing a buildup of cellular debris that leads to cell death. Clinical trials combining autophagy inhibitors with chemotherapy have shown mixed results, however, pointing to the complexity and context dependence of autophagy in cancer biology. There is a significant warning embedded in these findings. Autophagy is not inherently harmful. It is a fundamental survival pathway in healthy cells as well. Inhibiting autophagy systemically can harm normal tissues, especially those that rely on it for homeostasis, such as neurons, immune cells, and cardiac tissue. Chronic autophagy inhibition may even promote cancer development in the long term by preventing the clearance of damaged organelles and proteins, leading to genomic instability. Thus, while blocking autophagy in established tumors may improve short-term treatment efficacy, it carries long-term risks, particularly if used indiscriminately. Additionally, not all tumors respond the same way. In some cases, chemotherapy induces a form of lethal autophagy, where cells self-digest to the point of death. In these scenarios, autophagy serves as a mechanism of cell destruction, not survival. Inhibiting it could blunt the therapeutic effect. Therefore, the success of autophagy inhibition strategies hinges on a deep understanding of tumor biology. Is autophagy protective or destructive in this specific cancer type, at this specific stage, under this specific treatment? The future likely lies in precision modulation of autophagy, using biomarkers to identify tumors that rely on autophagy for survival, and applying inhibitors in a timed, targeted fashion. Combinatorial regimens that involve autophagy blockade alongside chemotherapy, immunotherapy, or targeted molecular agents may improve efficacy while minimizing harm. Nanoparticle-based delivery systems, for instance, might allow autophagy inhibitors to act selectively within the tumor microenvironment, sparing healthy cells elsewhere. In the broader context of aging and long-term cancer risk, the implications are sobering. Autophagy is vital for maintaining cellular integrity and preventing age-related diseases, including cancer. Overzealous inhibition of this pathway, especially in aging patients whose autophagic capacity is already compromised, could accelerate degenerative processes or even promote secondary malignancies down the line. The same process that helps a cancer cell resist therapy is also the one that keeps normal tissues functional under stress. In conclusion, autophagy plays a paradoxical role in cancer treatment. It can both suppress tumors in their early stages and enable their survival in the face of chemotherapy. This duality makes it a tantalizing but dangerous target. Inhibiting autophagy offers a potential avenue to overcome drug resistance and improve outcomes in aggressive cancers. But like many powerful tools, it requires precision, restraint, and a deep understanding of the biological context. In the war on cancer, the goal must be not only to destroy the enemy, but to avoid collateral damage to the body's own critical defense and repair systems.